So we are going to discuss when a patient develops hematuria. So what are the things we have to look into? What are the things we have to evaluate? That's only we are going to talk about. So what is the definition of hematuria? Definition of hematuria is presence of blood in the urine. That's it, as simple as that. And what are all the types of hematuria? Actually, the types of hematuria is one is microhematuria, or the urine will be normal. The presence of RBC will be determined only through microscopy. Otherwise, the urine color will be normal. And gross hematuria means there will be discoloration in the urine. The urine will be red in color. So that actually there is change in terminology. Previously, it was termed as microscopic hematuria. Now it is termed as microhematuria. And other than that, and it is also called non-visible hematuria. The recent terminology is non-visible hematuria. And what is non-visible hematuria is we have to find at least 3 or more than 3 RBCs per hyperfill in the proper in a urine sample. If you're finding 3 or more than 3 RBC in a urine sample, means we can coin the patient as having microhematuria or non-visible hematuria. And other terminology is gross hematuria. Gross hematuria means presence of discoloration in the urine along with presence of blood in the urine, presence of RBC. Gross hematuria means even small 1 ml of blood will change the color of urine. It will change the color around 1 liter of urine. So the amount of change in the color, that is the severity of the change in color does not correlate with the severity of disease. What I'm trying to say is, if the urine is very much dark in color means, and it does not need to be the severe disease. That is what it is they are saying. And the classification is, we have to classify based on the intensity, based on the origin, based on the relation to mixturation, and based on the causes, based on the etiology, and based on the associated symptoms. Based on the intensity, that is micro or gross hematuria. Based on the origin means, it can be the origin of hematuria can be from the systemic disease, or it can be due to urinary tract pathology. Urinary tract, genitourinary tract actually. It can be arise from the genital tract, or it can be arise from kidney or ureter, upper urinary tract and lower urinary tract. And based on the relation to mixturation, that is, there are 3 types are there. One is total hematuria. Total hematuria means the patient will void, the discoloration of urine will be present throughout the voiding. So usually the pathology will be from the arise from the kidney or ureter or bladder or prostate. It can be from the systemic cause also. So in the upper urinary tract, there will be passage of clots, and the clots will be in the cylindrical or worm-like shape. Why it is assumed it is in the cylindrical or worm-like shape means, it getting the shape from the ureter. So these clots are passing from the ureter, so thereby it is attaining the cylindrical or worm-like structure. If it is arising from the bladder or prostate means, it is below the ureter. So these clots will be big and irregular. So total hematuria means the patient will avoid the presence of blood will be throughout the urine. And terminal hematuria means the presence of blood only at the end of the mixturation. Usually the cause will be at the bladder neck or at the prostate. And there is another terminology called initial hematuria. Initial hematuria means the patient will pass blood during the start of mixturation. So usually the cause would be the urethral pathology. And based on the associated symptoms. Associated symptom means, usually there are one terminology called asymptomatic microhematuria, and other terminology called painless hematuria. The patient will pass blood in the urine and they will not have any symptom. The most common cause of painless hematuria is mostly urological malignancy, especially bladder CA. And there are some patients will have hematuria, and along with that they will have other symptoms also, especially urinary frequency, urgency, burning mixturation, and these and all will signify there is a underground inflammation, especially bladder inflammation, especially cystitis or other inflammations, pyelonephritis. And some patients will have loin pain, and they will have classical type of pain, radiating pain from loin to groin pain. So this signifies there is an underlying stone pathology, and that is causing the hematuria. And some patients will have gross hematuria and associated with pain, and the pain is usually due to the blockage of ureter because of the clots. So the blood clots sometimes will block the ureter, so thereby it causes ureter pain, and these patients will have hematuria along with pain. So these are by associated symptoms we can classify the patient, and along with that we can classify the patient based on etiology. What are all the causes means this is systemic causes. Mostly it can be due to bleeding disorders, especially hemophilia or thrombocytopenic purpura, thrombotic thrombocytopenic purpura, or it can be one of the manifestation of leukemia. And other causes are cirrhosis, and the patient using anticoagulants, and sometimes systemic hypertension. What are all the renal causes? In renal classes, we have to differentiate. We have to classify into two categories. One is there can be glomerular pathology, or it can be non-glomerular pathology. If the patient having hematuria because of glomerular pathology means they'll have dysmorphic RBCs because of the RBCs are passing through the glomerulus, thereby the shape will be altered. So there will be dysmorphic RBCs. Along with that, they will have proteinuria, and along with that, they will have RBC cast in the urine. And along with that, these patients will develop edema and hypertension because of proteinuria. They will have edema and they will have hypertension also. So what are all the causes? So usually glomerulonephritis. The examples are Alport syndrome, IgA nephropathy, and membranous glomerulonephritis, membranoproliferative glomerulonephritis, and those are all the causes for glomerular hematuria. And what are all the causes for non-glomerular hematuria? How will you differentiate glomerular from non-glomerular hematuria? Means if the patient developing hematuria because of glomerular pathology means they will have dysmorphic RBC. The patient developing hematuria because of non-glomerular pathology means they will have normomorphic RBCs. And these patients will not have any proteinuria, and along with that, the RBC cast will be absent. And there is one more differentiation is there. And if the patient is having non-glomerular pathology and these patients are having hematuria means it can be due to either renal collecting system, or it can be because of urinary tract, ureter, or bladder, or prostate, or urethra. If it is due to non-glomerular and it is arising from the kidney means these patients will have cast, RBC cast. The, so if the patient is developing hematuria, if it is due to glomerular pathology means these patients will have dysmorphic RBCs, and these patients will have significant proteinuria, and usually these patients will have cast. And if the patient is having non-glomerular pathology, if it is due to renal, if it is arising from the kidney means usually the RBCs will be normomorphic, and there will be significant proteinuria, and the cast will be absent. And if the patient is developing urological pathology is urological means the RBC will be normomorphic, and these patients will not have proteinuria. So how will you differentiate glomerular and non-glomerular means it is by the shape of RBC and with RBC blood, RBC cast. How will you differentiate non-glomerular within that non-glomerular? If it is due to renal means these patients will have proteinuria. If it is due to urological cause means usually they will not have proteinuria. And what are all the causes glomerular we already discussed, and what are all the causes of non-glomerular but it is arising from the renal system? So it is those causes are polycystic kidney disease, medullary sponge kidney disease, and it can be due to renal artery or renal vein thrombosis, or it can be renal cell carcinoma or papillary necrosis secondary to sickle cell anemia. And what are all the causes of urological causes? There are many causes are there. Mainly is carcinoma, stones, or urinary tract infection. The urethral causes are the same. Stones or carcinoma or infection. Bladder, the same, carcinoma. The bladder CA is the most common cause for gross hematuria in patients who are more than 60 years of age. And what are the other causes of hematuria which is arising from the bladder means that is cystitis, stone and trauma, especially because of transurethral resection of bladder tumor. And prostate, same inflammation. There are three things are there, especially in urinary tract. One is inflammation, another thing is stone, and another thing is trauma, and another last thing is CA. So these are all the four causes. And posterior urethra also inflammation, trauma, CA. What is Jagger's hematuria means? It is because of excessive. These patients will have hematuria after going for jogging. So it is one of the cause of exercise induced hematuria. So this is one of these are the causes of hematuria. And so I discussed about classification based on intensity, based on origin, based on relation to micturition, based on associated symptoms, and based on etiology. So now I will go in for evaluation. So hematuria, first thing, hematuria of any degree should never be ignored. And another thing is adults should be regarded as symptom of urological malignancy unless and until prove otherwise. The thing is, hematuria is if the patient developing hematuria means we have to rule out urological malignancy. That is the main thing. So there are four things are there. One is what are all the causes means. The first thing is it can be because of non-malignant genitourinary causes, that is infection, stone related pathology. The other thing is the genital tract, especially female genital tract. Some the patients having atrophic vaginitis and the patients having pelvic prolapse, these patients will have hematuria. And other than that, if the patient is in menstrual bleeding means these patients will have hematuria. And other thing is the patient is in pregnancy means those patients will also have hematuria. And we have to differentiate non-malignant genitourinary pathology, and we have to differentiate the genital pathology, and we have to differentiate the renal pathologies, especially medico-renal disease, especially glomerular pathology. If you are excluding all things means still the patient is developing still the patient is having hematuria means we have to look for genitourinary malignancies. That is the main thing. The patient is developing hematuria means our ultimate goal is to exclude the genitourinary malignancy. So how you are going to identify hematuria? This thing we have already discussed in the basic urine analysis. We have to collect the midstream urine. We have to discard the initial urine to remove the squamous cells, and we have to collect around 10 ml of urine in a sterile container, and it should be processed within 3 hours. And we have to examine the urine specimen under 400 times. Magnification is around 400 times in the phase contrast microscope. So what are we going to do? First thing we are going to do is urinary dipstick. Urinary dipstick, what is the methodology? In urinary dipstick method, if the patient is having HB, that is hemoglobin in the urine means the dipstick will have chromogen. If the patient is having hemoglobin in the urine means when we are mixing the urine with dipstick, this hemoglobin will peroxidize the chromogen and it will cause color change. What is the reaction which is happening is oxidation reaction. Oxidation. And this color change will be depend upon the degree of hematuria. If the patient is passing less than 10 RBC means the dipstick will have spot like color changes. If the patient is passing more than 25 RBCs means Usually it will be prostate. So, and one thing is there are many false positive causes. There are causes many false positive results will be there. What are the causes for false positive results is one is presence of semen in urine. So we have to ask the male patients to retract the prepuce before passing before giving sample, and for female patient you have to retract the labia. What are the other causes of false positivity? That is presence of hemoglobinuria, not RBCs. Presence of hemoglobinuria. Another thing is myoglobinuria. And what are the other causes means presence of oxidizing substance, oxidizing agents. Because the reaction which is happening is oxidation reaction. So what are the oxidizing agents? Most common is iodinated agents, iodinated contrast agents. And usually false positivity will be the pH will be in the alkaline range. These are all some of the causes of false positivity. What are all the causes of false negative results? Presence of reducing agents in the urine, especially ascorbic acid. Specific gravity will be low, very much low, and pH will be very much low in this patient, in false positive. So one thing, how you are going to differentiate hemoglobinuria from myoglobinuria? Myoglobinuria is, so we have to get the sample of the patient, the blood sample of the patient, and we have to centrifuge the blood sample. And after centrifuge the patient, after centrifuge the blood sample, we have to look the supernatant fluid. If the supernatant fluid is clear, means it is usually myoglobinuria. If the supernatant fluid is red color shape or change in color in the supernatant fluid, means it is usually due to hemoglobinuria. So why the color change in the hemoglobinuria means usually the hemoglobin will bind with haptoglobin, and that is causing the color change in the supernatant fluid. Myoglobin will not bind with haptoglobin, so that way the supernatant fluid will be normal in color. So I have discussed the urinary. So how it is showing positivity and what are the false positive and false causes, and I have discussed about the hemoglobin and myoglobin. Now comes the deciding authority, and who is giving the guidelines. What we should do if the patient is having hematuria, means what is the next step, and this is decided. Usually we are following American Urology Association guidelines, and another thing is Society of Urodynamics and female urology. So they are giving the guidelines. The latest guidelines is it came in March 2020. Around March 2020, the latest guidelines. And the thing is, for hematuria, the Urology Association only have given the proper guidelines. Either KDGO or other nephrology association, they have not given any proper guidelines for approach to hematuria. So we are following American Urology Association guidelines. What is the guideline? This is the recent guideline. So many things we have already discussed. First thing, if the patient with hematuria, that is more than 3 RBCs per high power fluid with microscope. And one thing, if the patient is having positivity in urinary dipstick, means we should not confirm the presence of hematuria. The presence of hematuria should be confirmed with the help of microscopy. That is phase contrast microscopy. If the patient is having three or more than RBC in a phase contrast microscopy, means that indicates the presence of microhematuria. And we have to ask the history and physical examination, and we have to find out the non-malignant or gynecological source of the source etiology. They're saying, if you are able to find out the non-malignant and or gynecological source, means we have to treat that cause, and we have to repeat the urine analysis. If the repeat urine analysis is negative, means we can release the patient from care. And if the so first thing, if the patient is having hematuria, means we have to ask history and physical examination. We have to find out non-malignant or gynecological source. That is, if it is positive, means we have to treat that cause. We have to treat that cause, and after treating that cause, we have to repeat the urine analysis. If the repeat urine analysis is negative, means we can release the patient from care. And if the patient for genitourinary malignancy, there are 3 categories. We have to categorize the patient. That is, patients having low risk, intermediate risk, and high risk. If for low risk, the patient should have all of the following. For intermediate risk, the patient can have any of the following. For high risk, the patient can have any of the following. What are all the risk factors? For low risk, means first thing is age, then smoking history, then number of RBCs, then risk factors for urothelial cancer, and other thing is presence of gross previous episodes of microhematuria. If the patient is age of patient is less than 50, especially women, men age more less than 50, less than 40, and if the patient is never smoker or less than 10 pack years, and the presence of RBCs 3 to 10 RBC per high power field on urine analysis, and there are no additional risk factor for urothelial cancer. That means what are all the risk factors for urothelial cancer? These are all the risk factors for urothelial cancer. That is, history of cyclophosphamide or ifosfamide usage, family history of urothelial cancer, and presence of Lynch syndrome. Lynch syndrome means family history of hereditary non-polyposis colorectal cancer will be there. That is Lynch syndrome. Then occupational exposure to benzene or aromatic amines. Then presence of chronic indwelling foreign body in the urinary tract. These are all some of the risk factors for urothelial cancer. And for low, if the patient if you want to stratify the patient as low risk, means these patients should not have any of the risk factor, and there should be no prior episodes of microhematuria. This should be the first episode for the patient, and this is for low risk patient. For intermediate risk, the age should, for women the age should be 50 to 59, for men the age should be 40 to 59, and the pack year should be 10 to 30 pack years of smoking, and the presence of RBC should be 10 to 11 to 25, and there should be one or more additional risk factor for urothelial cancer, and these patients can have previously low risk or no prior evaluation, and there is 3 to 25 RBCs and repeat urine analysis. For high risk, the age should be more than 60 years. If the age itself more than 60 years, means these patients are high risk for, there is no need for other criteria. So if the patient age is more than 60 years, those patients are high risk. And the smoking is more than 30 packets of smoking and more than 25 RBCs per high flow feed, and the presence of gross hematuria. If the presence of gross hematuria, means one of the high risk for your genitourinary malignancy. And previously ROR is no prior evaluation, and the RBC is more than 25 RBC. It is same. This is 11 to 25 and 3 to 25. That is up to 25 is intermediate risk, more than 25 is high risk. So if the patient is having low risk, what we are going to do? We have to do shared decision making. What they are saying is we have to make a decision whether we have to repeat the urine analysis within 6 months or we have to directly go for imaging. The one thing is that I forgot to mention is we have to rule out the first thing I said is we have to rule out non-malignant or gynecological source for hematuria. In the source, there is medical renal disease also will be there. That is renal cause also one of the cause for hematuria. So what we are going to do is we have to go for biopsy. And here first we are going for imaging. If we are sending the patient for nephrology, means there they will do biopsy first. And if you are going for urology for especially for ruling out genitourinary malignancy, there we are going to do imaging. For low risk patient, we have to make a decision whether we have to repeat urine analysis within 6 months or we can go for cystoscopy and renal ultrasound. That is for all patients, all category patients, cystoscopy is a must. Along with that, for low risk patient, you have to make a decision. If you are making a decision for going for imaging, means cystoscopy is a must. For intermediate risk patient, we can directly go in for cystoscopy and renal ultrasound. For high risk patient, we have to go for cystoscopy with CT urogram. That is multiphasic CT urogram. Previously, CT urogram was the investigation of choice for all type of for ruling out all type of genitourinary malignancy. Now they have stratified the patient, and according to the risk, they are going for evaluation. And we have evaluated the patient. For low risk patient, if the repeat urine analysis is negative, if the evaluation is performed, if the evaluation is negative and the repeat urine analysis is negative, means we can consider the another one sample for urinals within 12 months. If that is also negative, means we can release the patient from care. So here they are doing two samples. If the first is negative and the second is negative, means they can release from the care. And for low risk patient, if first is negative and the second is positive, means you have to go for evaluation, either evaluation or observation. For intermediate risk patient, if the evaluation is negative, means the same thing. You have to repeat the urine analysis within 12 months. If it is negative, means there is no need for further evaluation. If it is positive, means we have to make a decision whether we have to observe the patient. First thing, if the patient is having hematuria, means first we have to rule out non-malignant causes. What are all the non-malignant causes? That is infection, stones, renal, especially glomerular pathology, and other causes, non-glomerular, non-malignant causes. We have to exclude pregnancy. We have to exclude patients who are in menstrual period. These are all the main things. We have to exclude all the non-malignant causes. For infection, we have to treat the infection, and we have to repeat the urine analysis. If it is repeat is negative means no further workup. If the patient is having renal stone, we have to treat the patient and we have to repeat the same thing. If the patient is having glomerular pathologies, we have to do renal biopsy. And we have to treat the cause. Usually pregnancy, these patients will normally have hematuria. So we will exclude the patient. We have to do repeat urine analysis after pregnancy. When we will do workup if the patient is having hematuria in pregnancy means if it is causing endanger to the child and mother. Or else if the patient is having hematuria during menstrual bleeding means after the cessation of menstrual cycle, we have to do repeat urine. And it can be due to exercise induced. So we have to do repeat urine analysis after taking rest. These are all the non-malignant causes. So once you are ruling out non-malignant causes means we have to risk stratify the patient. For genitourinary malignancy that we have discussed. Overall is mild, moderate, mild, intermediate, or high or high risk. For mild, we have to do repeat urine analysis or imaging, that is cystoscopy or renal ultrasound. For high risk patients, we have to go for cystoscopy with CT urography. Some patients they'll have contraindications for CT urography means we can go for MR urography. If you are not able to do MR urography also means we can go for retrograde pylography. And along with retrograde pylography, we can either go for non-contrast CT or renal ultrasound. For these two patients, we have to repeat the urine analysis. The main thing is if two consecutive annually, if two consecutive repeat samples are negative means there is no need for further workup. If the repeat sample is positive means we have to go for imaging, that is CT urography. These patients we have not done CT, so we have to go for CT urography or retrograde pylography. So on one thing, you are doing these imagings. If you are finding out any cause, if you have localized the lesion means we have to treat the cause. Oh, this is the ultimate approach for hematuria. And what are all the things? There are 22 recommendations. So the important recommendations I will say. First thing is urinary dipstick method should be confirmed with microscopy, urinary microscopy. To classify patient as hematuria. Other things are the patient is taking anticoagulants means these patients will have hematuria maybe due to, but for the patients also we have to work up for other causes of hematuria. That is important. So the many of the times in our ward also some patients will be taking heparin or warfarin. So we usually will do we will classify the patient it is because to anticoagulant. So for that patient hematuria. Another thing, the patient is having hematuria because of glomerular pathology. For these patients also, along with biopsy, we have to risk stratify the patient. For urological malignancy, that is urological malignancy. Should not forget, the patient is the hematuria is because of glomerular pathology means we should not stop with biopsy alone. We have to work up for urological malignancy also. And these are all some of the salient points. I'll show you the recommendation. So these are the to define a microhematuria. There should be more than three or more than three red cells per hypertrophy. And clinicians should not define hematuria by urinary dipstick method alone. A past urinary dipstick should be confirmed with urinary microscopy. And the patients are with microhematuria means you have to take a proper history and we have to take a physical examination. We have to assess the risk factor for genitourinary malignancy, medical renal disease, gynecological or non-malignant genitourinary cause of microhematuria. And we should perform the same evaluation of patients with microhematuria in patients who are taking antiplatelet agents or anticoagulants that I already discussed. And patients suggestive of gynecology or non-malignant pathology, urological causes for microhematuria means the clinician should evaluate this patient with the appropriate physical examination and test. And if you arrive at the diagnosis means, and we have to treat the gynecology or non-malignant causes for microhematuria. And after treating the patient, we have to repeat the urine analysis. If microhematuria still persists or etiology cannot be identified means we have to stratify the patient. If the microhematuria attributed to urinary tract infection means you have to obtain the urine analysis after resolution of symptoms. And the clinician should refer microhematuria for nephrological evaluation means for medical renal disease means. However, we have to stratify the patient for urological malignancy. And following initial evaluation, after ruling out all these causes, all these non-malignant causes, we have to stratify the patient as low or intermediate or high risk. For low risk patient, so the clinician should start decision making whether repeat urine analysis or we have to proceed go with ultrasound or not. For a low risk patient, if the who are initially not undergo cystoscopy or urinary tract imaging and were found to have hematuria on repeat urinary testing. That is, the repeat urine first urine analysis is negative and the repeat test is positive means we have to again classify it as intermediate high risk patient. That is according to the number of RBC that we have discussed. That is up to 25 means that is intermediate risk, and more than 25 means that is high risk. In such patients, we have to perform cystoscopy or urinary tract imaging. For intermediate, directly we have to go for imaging. For high risk patients, if there are no contraindication, we have to go for multi-phasic CT urography. If there is contraindication for multi-phasic, we have to go for MR urography. Still, if the patient is not able to CT or MR urography means we can go for retrograde pyelography, and along with that we can go for non-contrast and imaging or renal ultrasound. And one more thing, if you are suspecting, if the clinician is suspecting the cause of hematuria may be because of bladder pathology means we have to do white light cystoscopy. There are two forms, blue light cystoscopy and white light cystoscopy. For these patients, you have to do blue light cystoscopy. When the patient is having persistent or recurrent hematuria and previously evaluated the renal ultrasound means we have to go for additional imaging, that is for CT. And one more thing, if the patients having hematuria and the patients have family history of RCC or other genital renal tumor syndrome means these patients should perform urinary tract imaging regardless of category. These are all some of the exceptions. If the patient is having family history means we have to directly go for imaging. And one more thing regarding urinary markers, that is urine analysis for cytology. If the patient is having during initial evaluation, we should not rely upon urinary cytology. Clinicians should not use urinary cytology or urine-based urinary markers. When you should take a urinary cytology or urinary marker means even if the patient is having negative workup and still the patient is having symptoms means we may obtain urinary cytology to rule out urological malignancies. And regarding follow-up, the patient having negative hematuria, we have to repeat the urine analysis. If the repeat is negative means there is no further workup. This I have already discussed. These are all the 22 recommendations from American Urology Association. So whenever the patient having hematuria means you have to approach a patient like this one. So that's it.